Why does American healthcare cost more than anywhere on Earth? Congress spent the day on that question, clashing over drug middlemen, direct contracting, and who gets left without coverage. It got heated fast. Here's what happened, then the facts behind it.
Thank you, Mr. Chairman. Mr. Woodhouse, do you think it's okay to lie to Congress?
I don't know. Are you lying to Congress?
All right, I'll take that as a no. You said in your testimony that 15 million Americans would lose their health care. Do you stand by that statement?
That is what the CBO said.
Do you know what an American is? Do you know what an American is? Do you know what an American is?
CBO.
No, that is not what the CBO said. Do you know what an American is?
Absolutely what the CBO
said.
Okay,
so when the CBO said that millions of, even in that nonsense statistic you gave, that included health care for non-Americans. So you clearly don't understand what the difference between an American and a foreigner who's getting health care coverage is. Given that you sat here and lied, and I gave you the chance to correct yourself, I'm not interested in anything else you have to say.
Okay.
And I don't think anyone else in this committee has as well. Your time is done. I will move on. You can shut your mouth. You lied to Congress. Mr. Newman,
Point of order.
Mr. Newman.
He's accusing the witness of lying.
I am, and I proved that he lied, and I'm moving on with my questions now. Mr. Newman, you testify that for every dollar of care delivered, employers pay $1.30.
Mr. Chairman, I demand that the member's words be taken down. He's accusing somebody of lying.
He did lie. You want to debate it? He lied. That's not in debate. No one has said.
Mr. Chairman, I ask that his words be taken down.
He lied. He lied. I gave him the chance to correct it. He chose not to, and it was a lie. It's objectively false, the testimony he gave before this committee. I even asked him, does he know what an American is?
Yes, Conho from California for his 5 minutes of questioning.
Thank you, Mr. Chairman. Mr. Woodhouse, 5 million Americans have been kicked off Affordable Care Act coverage just in the past year. You say it's 8 million?
It is.
How much more do you think, how many more Americans do you estimate will be kicked off of health care either through the ACA or Medicaid?
Well, so the CBO estimate when H.R. 1 passed last year was that 15 million collectively would lose coverage between the Affordable Care Act, tax credits going away, and the Medicaid cuts.
But what's the estimate?
15 million was
15
was
million.
CBO
15 million are going to lose their health care
altogether.
Dr. Savage, does the increase in the uninsured put significant pressures on the rest of the healthcare system to deliver healthcare at an affordable price?
Not necessarily. Actually, the closest thing we've ever had to a randomized study on this was conducted in Washington and Seattle.
Oh, so not necessarily. Not necessarily. That doesn't seem like a very strongly held opinion. Yes or no?
Well, that's not.
Yes or no, sir?
Question. I abstain.
You don't. You abstain. You don't. So you don't have. You're not really sure.
Well,
so you really can't answer with great conviction that 15 million people kicked off of health care in America won't drive up costs for everybody else.
Health insurance.
You can't say health insurance, well, they're going to be uninsured. Will that not put pressure on everybody else and the prices to go up for everybody else? You're not sure.
If those people engage in the free market and purchase, they will get better prices.
Okay, you're going to answer the free market, but I'm going to tell you that in the immediate term, I think most people would answer that question yes. Mr. Newman. Answer the same question. Will 15 million people kicked off of health care in the next year or so drive up, put pressures upward for everybody else?
No, I don't believe it will.
You don't believe so. Thank you. Mr. Gelfand.
So far, we have not seen those.
So far, we've not seen. So far, we've not seen, but you're not really sure. I would contend that most people with common sense would say that 15 million people losing their health care insurance as a beginning. Mr. Woodhouse, do you want to opine on this?
I mean, absolutely. There is no doubt that all these millions of people losing coverage, we all know, everyone here knows about the issue of uncompensated care. People show up at the emergency room, they have to be cared for. There is a requirement to care for someone in an emergency room, whether they have coverage or not. Those costs move on through the healthcare system. It makes coverage, it makes everyone's premiums go up across the board. Premiums in the private marketplace are going up more this year because of the anticipation of uncompensated care than they did last year, and then premiums are obviously going up for the people that lost the tax credits. That's over 20 million people.
Thank you. Mr. Gelman, this contracted care is very interesting to me, and I do believe that it will drive efficiencies and bring down costs for large employers. You seek to make it possible for mid and small employers. You talk about local networks. What about rural America, where there's a shortage of both family providers and specialized care, and the problem of private equity buying up providers, and in some areas we have maybe just one provider network. How will direct contracting lower costs in those situations?
Direct contracting is an alternative to those areas where there's only a single network. I mean, the domination of incumbent carriers with bad service, terrible pricing,
but we're
and
talking
bad
about
policies that put providers out of business.
A single network, but we're talking where there may be just a shortage of providers, period, or where there's one provider group that you got to negotiate with.
Yeah, you lose providers because they can't stay in business. They're burned out dealing with insurance companies and junk plans trying to collect to get paid, and patients who can't afford care.
So you think that the shortage of rural providers is a result of the fact that we have an inability to keep them in the community?
If we simplified the business of healthcare, the delivery of healthcare is a high net promoter score in America. The business of healthcare is the sickest patient on the planet. And if we made it easy for rural providers or urban providers or big providers or small providers to actually get paid for the work that they do, which employers are willing to do on their behalf because the insurance companies don't.
How does that solve the problem of rural hospitals closing?
It keeps them in business. Most hospitals don't go out of business because of lack of revenue. They go out of business because of lack of cash. And the lack of cash to keep them in business is a direct derivative of the terrible policies that big insurance companies inflict on America.
Well, I would say I wish you luck. Big employers being able to self-insure, I don't know how we arrive at the same. I'm running out of time, but I'd love to pursue this with you further. Thank you.
Absolutely, it'd be fun.
Okay, a little bit of business here. The gentleman from California has asked the gentleman for his words to be taken down. Does the gentleman wish to ask unanimous consent to withdraw or modify the words to which the gentleman objected? Mr. Fine, do you?
No, I'm not taking my words down, so no.
Okay. All right, and the chair is prepared to rule in the opinion of the chair. The gentleman's words are in order.
Mr. Chairman, I'd like a vote, please.
Okay, so we'll take
Voice vote.
So we'll take a vote. All those in favor, signify by saying aye. Aye. All those opposed, no.
No.
No?
In the opinion of the chair, the ayes have it, and the motion to table is not agreed to, and the gentleman has 3 minutes and 54 seconds remaining.
Well, thank you, and I want to thank the ranking member for pointing out that lying to Congress is a crime. I'm going to move on to the questions I was going to ask. Mr. Newman, you testify that for every dollar of care delivered, employers pay $1.30 in plan costs. Providers receive 80 cents. Could you help us understand what accounts for the remaining 50 cents, or approximately 62.5% of the amount paid to providers? Where in the system are those costs incurred?
Excuse me. Thank you for the question. The committee has spent an enormous amount of time bringing transparency to PBMs, right? And there's this concept of spread, where it was, a misplaced dollar that went from one place to another. The medical side and the difficulty of it comes because that spread comes from a variety of sources and places. For the provider side, here's the reality. If you look at any public filing from any public hospital system, regardless of plan type source, right? Marketplace, self-insured, Medicare, Medicaid, you name it, there is an average write-off of 75% of patient balances tied to deductibles and other things like that they go uncollected. That is regardless of market type. So right out the bat, if in your market, you're reliant on 30% of your revenue coming from patients, well, guess what? There's 22 points right out the door, right? It has that shift. The second part of that is payers don't pay. On here, you've dealt with countless hearings around insurance companies and the prior authorizations and denials of claims and all those things. That adds another 5 to 10% of seepage, off of this. And then your typical health system, because of the complexity of U.S. healthcare, figuring out how to get paid, who to get paid by, when to get paid, chasing after them, you name it, is spending somewhere between 12 and 15% of their operating budget just trying to figure out how to get paid. I mean, you've run businesses. A 15% cost to get paid is not a functional marketplace. So that all adds up to that 20 to 30% in any place, in any market, in any provider. On the employer side, on fully insured plans, this has been the margin on top of a medical loss ratio, but in the self-insured space, it shows up as admin fees, transaction fees, clawback fees, consultant broker, kind of fees, stop-loss carrier rates that are inflated because of the fact that they have no data or no visibility. That's the problem with this grift is that there isn't one single boogeyman, right? That's why we have to rebuild the system and simplify it. It's not a renovation, because it'd be the renovation from hell.
Well, thank you, and thank you for your answer. Look, I think that we've got real problems in the healthcare system. I think the biggest one is that we've detached who pays for the service from what the service costs. And when you can buy something and you don't know how much it actually costs, you tend to buy too much of it. There's a reason the market works. When prices go up, people are willing to supply more of it, but they typically are willing to purchase less of it until you reach that equilibrium. In healthcare, we've broken that. Because if you have a copay of $10 to go to the doctor, if you think you're going to get $11 worth of value going to the doctor, then you're going to go to the doctor. Even if going to that doctor costs $200, you're not thinking about the right way. I think your model helps us do this. But no matter what our issues are as it relates to healthcare, if we're going to solve them, it is essential that we deal in the world of facts, that we deal in the world of reality, and we deal in the world of truth. So thank you all for being here, and hopefully moving forward, we can begin to do that a little bit better.
Minutes of questioning.
Thank you, Mr. Chairman, and thanks to the panel for being there. Although I have to say, Mr. Woodhouse, your numbers are absurd. I checked with Dr. Onder here, and he found very easily, because media won't do the research, but you can do the research, in the marketplace, 23 million souls are on the marketplace. And you're saying 20 million. I'm not asking you a question. Okay. I'm getting forth the absurdity of what you're saying. 15 to 20 million don't have health care, when on the marketplace there are only 23 million, nearly 23 million. Correct, Dr. Onder? Correct. Let's move on here. The shilling that goes on for the Unaffordable Care Act is absurd as well. Mr. Newman, thank you for coming all the way out from Utah to be with us. Your written testimony highlights that employers using Know Me Health direct contacts in my home state has caused some of the Michigan medical spending per member fall by as much as 29%. That's great. Could you expand on how employers were able to see a reduction in cost despite the statewide commercial market average continuing to rise by 10 to 15% annually?
Excellent. Yeah, thank you. And thanks for all the work that you do to address this issue. Incumbent-dominated markets, Michigan is one of those, right, where there's a very dominant local insurance company, has generally abused their market position for a very long time. And there are three paths to solving this problem. The first is ultimately, in the simplest, lower contracted rates. But how do you get to those lower contracted rates? Well, you have to solve actual business problems for providers and not be the ones continually trying to drive them out of business. So we contract with providers at a direct, real price of healthcare, solving their business problems, just like the story I told, being able to pay at the time of service in full for the claims and the service that they deliver. There is a real price of healthcare that exists, and that solves our 20 to 30% problem in America. But second, the admin fees that employers are thrown at are just as heinous. This shows up as junk medical loss ratio, margin coverage, whatever it might be, to ASO fees, to clawbacks, and all the other bells and whistles that get thrown in. Employers know how to buy and pay for things, and we should do it as simple and efficient and easy as Visa and MasterCard or American Express can, not at a 15 or 20% margin that any insurance company claims that they need. Yeah. And then third, all the other parties around this system, for self-insured employers like stop-loss carriers and other people, they have traditionally been completely cut out of any data, any rate visibility, or any direct relationship as a party to catastrophic risk or other things in those parts of it. And all they do is have to price in that risk of non-payment, no service, and bad transparency. And if you bring it open, if you simplify the system down to its core, where a provider can deliver care and get paid for it. And if a consumer can do it, great. But if not, an employer can do it on their behalf. Yeah. That's the nugget that we unlock everything in employer health care.
Common sense, like other products and purchases. Great degree.
If we ran restaurants like healthcare, every restaurant would be out of business in America.
Let's not start that then. Thank you. Dr. Savage, thanks for coming in all the way from Brighton, Michigan. Glad to have you here, especially since you're practicing in the field as well. Healthcare costs continue to rise at an unsustainable rate. National health expenditure data showed a 7.2% growth in healthcare spending in 2024, and total of $5.3 trillion in healthcare spending that year. What would be the single most impactful thing that could be done to reduce healthcare costs in the United States?
Yeah, well, one of the best mechanisms to access what we've been talking about are HSAs because they're pre-tax. But right now they're limited in their potential because they're mandated to be linked to high deductible health plans. I think that should be severed, that they can exist on their own and that the pre-tax basis of those could be used to purchase a variety of coverage products that the patient wants, not necessarily that they're mandated to obtain. What this would do is free employers from needing to provide coverage, because the reason it's provided through employers right now is because it's done on a pre-tax basis. This would get people who buy it on their own essentially the same tax advantage as people who obtain it through their employers. This would have a massive domino effect which would benefit the whole system, freeing employers to focus more on their core business instead of being de facto insurance brokers. And also it would allow patients to own their own coverage so they're not stuck in job lock. Because they own it over time, they're less susceptible to pre-existing condition issues, and it would engage them to become arbiters of medical pricing, which would exert downward price pressure constraining the excesses of the whole system.
Again, simple common sense ideas that can work around an unaffordable Care Act that's caused significant problems. Thank you so much. My time has expired. I yield back.
Thank you, Mr. Chairman. When we discuss skyrocketing healthcare costs, there is a misperception that physician payment and prescription drugs are driving costs. This graph shows national total healthcare expenditures over the past 10 years, which have risen from $3.2 trillion to $5 trillion. The dark line at the bottom shows physician and clinical services roughly stable at about 20% of spending. The middle blue line shows prescription drug costs rising a little bit, but roughly 10% of total spending. And then the upper graph is everything else. This hearing is critical because we have to focus on this segment of healthcare costs that is not improving patient care, it's driving up costs for patients and employers. One of the ways we can rein in these costs was alluded to earlier is through increased transparency. Employers have little visibility when it comes to knowing what they are actually paying for, which fuels overpayment. That's why I worked with this committee on H.R. 9228, the Health Data Act, which would require insurers and other intermediaries to share data on all expenses when the employer is footing the bill. Mr. Gelfand, can you explain how access to meaningful data can help root out wasteful spending and ultimately lower costs to patients and employers?
Thank you, Doctor. Meaningful health data can help employers identify waste, compare prices and quality, and direct employees to higher value care. Nearly 1 in 4 healthcare dollars today, an estimated $760 to $935 billion every year is spent on waste, including unnecessary care, administrative inefficiencies, and pricing failures. With access to claims data and price and quality data, employers could eliminate high-cost, low-value care from their networks, and we could design smarter benefits that would lower costs for the 160 million Americans who get health care through their job. For example, if Congress passes the Transparency in Billing Act, employers will be able to find and eliminate inappropriate facility fees. We will be able to spot upcoding and downgrade those charges to more appropriate levels and save billions of dollars for patients. And if Congress passes your bill, the Health Data Access, Transparency, and Affordability Act, employers will be able to match the money that they pay to the bills that we receive and ensure that the right amount is sent. We'll be able to identify the best providers and systems and improve our networks, and we'll be able to stamp out fraud that otherwise might go unnoticed, because right now, fraudulent bills just essentially get paid on autopilot. So we hope that Congress will pass your bill.
Thank you, Mr. Gelfand. The other way we can tackle this portion of the chart that is driving healthcare costs is to cut middlemen out of the process and empower employers to negotiate directly with physicians and hospitals. One of the largest employers in my district, Boeing, recently began offering direct primary care services to its employees, and it's extremely popular because the patient and the employer have predictable, reasonable expenses, and physicians can spend more time with patients and less time arguing with insurance companies. In traditional insurance plans, it's been estimated that doctors spend on average 2 hours on administrative tasks for every hour they spend with patients. Mr. Newman, can you share how NOMI Health Facilities real-time payments to providers, how it facilitates real-time payments to providers, and how you're able to do that to scale?
Yes, and before that, just thank you for HR 9228. It's a transformational piece of legislation.
Thank you.
We have to open up this black box. If we open up this black box, we know then what we can do about that black box, right?
Yes.
And kind of what's in it.
Yes.
When you go to a restaurant, you get the bill and you pay for it. It's that simple. It doesn't cost much. There might be a credit card fee. But in healthcare, the cost to get paid for a provider, like you touched on, administrative cost, burden, you name it, is weeks, months, is hours, and is about 15 to 30% of the cost.
Yes.
Boeing's model and others like that, when they just pay, it turns out healthcare is cheaper.
Yes.
And that's the model that we should adopt everywhere.
Well, thank you. And Dr. Savage, I want to emphasize something. You said the primary care is the lowest cost. And with direct primary care, we do not have a large, let's say, hospital employer looking over the doctor's shoulder saying you need to order more tests, more x-rays, refer to more of our employed specialists. You have the doctor looking out for the patient. And I can say from my own experience, when I got a call on the weekend, the patients I knew the best, who I had been taking care of, say their asthma, that was my specialty for years, or their allergic reactions for years, they were the ones I was least likely to send to the emergency room because I knew the severity of their condition. I could reassure them, no, do this, do that, and this is my cell, call me back if you need me. Someone who I didn't know at all, I was covering for another physician in another practice, I didn't know them, I had to send them to the emergency room. So thank you, Mr. Chairman, and I yield back. Thank you all for your testimony.
The gentleman yields now. I call on Ranking Member DeSaulnier for his 5 minutes of questioning.
Thank you, Mr. Chairman. Mr. Woodhouse, I want to give you a moment to explain yourself. What I heard you saying was referring to the Congressional Budget Office of H.R. 1, correct?
That is correct.
That
is correct. The H.R. 1's, the CBO analysis looked at two things in terms of coverage losses. One was roughly 10 million that would lose coverage through the Medicaid cuts, the $1 trillion in cuts over time. 5 million who would lose coverage as a result of losing the tax credits. That's 15 million people in America. That I was not suggesting anything otherwise in my oral or my written testimony.
Okay. One of the things that's frustrating about healthcare, having dealt with it for a long time now, is in the private sector as an employer. And Mr. Newman, your references to the restaurant business, I appreciate. Having met a payroll for many years in the restaurant business, including trying to provide health care for my employees. I remember once having a manager in tears because she couldn't make her deductible, so I paid her deductible. So this hearing is sort of an example of what's wrong with Congress when it comes to health care. And Mr. Chairman, you and I have really good conversations, whether it's PBMs or denials by United Health or others. We could, if we analyzed healthcare the way we analyzed our businesses, I still think could make meaningful differences. However, when you have the kind of misrepresentation and political theater on the extreme that we had today, it takes away from our ability to concentrate. Mr. Woodhouse, in that mixed market, I have a private healthcare system, John Muir Health. My district is the 5th wealthiest in the United States, so there's a lot of private pay. They're consistently in the top 20 hospitals in the United States. 20 years ago, their payer mix was 98% private. Now they're almost 50% Medicare. That's a mixed market. So they told me if the big ugly bill went ahead, because of their payer mix now, they would have to close hospitals, and we're struggling with keeping them open. One of the wealthiest hospitals in the country. Could you sort of follow up on that framing of how this, to your point, this is not an issue just for the genius of the private sector. It requires ambulances, emergency response, public hospitals, public emergency rooms. This is a mixed market system. We have to fix it in that context. It takes some private sector, but it also needs some guardrails.
It does, and what we saw was the minute H.R. 1 passed and was headed to the president's desk, the first hospital announced its closure because of what it anticipated was the financial pressure that it would receive. Now we're tracking over 1,000 hospitals, clinics, providers that are either have closed a ward, cut a ward, or are at threat of closing. And these are, in many places, the only opportunity people have to get care. They go somewhere else, it costs more. It costs more throughout the system. I think those of us that were in favor of passing the Affordable Care Act, we made a bargain with the private sector, with the insurance companies, that we would have this mixed market, that we would have, they would have a broader market, they would have more patients, they would get rid of stuff like, eliminating people because of pre-existing conditions. We'd keep premiums as low as we possibly could. And the cuts to H.R. 1, the $1 trillion in cuts have just put so much more pressure on the market overall.
So Henry Kaiser created the Kaiser healthcare system. He started it in the East Bay in California, where I represent, because he wanted his employers to have, well, he also started childcare, but healthcare. So it was a good model of a public or a private sector employee meeting the needs of his employers. But it's now a closed system. It was a closed system then, you had to be an employer. But it works and it controls their costs, but they still struggle with every little piece. So let's talk a little bit about prescription drugs. And it's not, as Dr. Oz just said, it's not a huge section, but it's a significant section. Mr. Gelfield, could you respond to some of the things we've been able to do just to reduce prescription drug costs?
So already Congress has passed reform of pharmacy benefit managers. Thank you for your support there. That's going to make a huge difference. We hope this committee will also consider making PBMs a fiduciary to the health plans that they're involved with. We also have been very supportive of a number of changes related to Big Pharma and the way that they extend their patents. For instance, the Ethic Act, in which we would eliminate these patent thickets in which a drug might have 5 or 6 patents in Europe and 500 in the United States. There's a lot of little things that we could do to make prescription drugs more affordable.
Member, for your closing remarks. If there are no further questions, I think we'll close out. Mr. Ranking Member, your closing remarks.
Thank you, Mr. Chairman. I'd be curious if what CBO says, and as I've quoted also, Kaiser Family Foundation analysis of H.R. 1 is true, and I've heard the chairman of the full committee say that when testimony I was making, I was scaring people and misleading Americans by quoting CBO, as Mr. Woodhouse did today, and in my case, Kaiser Family Foundation, we didn't accept that. Maybe the majority would accept a bill that would amend H.R. 1 to say, if these things come into fruition, how do we stop it? Because this is disastrous. And you can see it in real time right now. In the district I represent, we spent a long time going upstream to do clinics, to do primary care doctors in an integrated system between the private hospitals and the public hospitals. It worked. It got people out of the emergency rooms. I was out there recently, and what they said was, it's going back to the old model. People will have higher acuity, and when they seek help, it won't be from their doctor or primary care doctor. It'll be at the county's emergency room or the trauma center. I don't see how that works as a business model, besides the inhumanity of letting Americans suffer like that as it's happening. So, Mr. Chairman, I would just say, as always, I think you and I have a perspective as an employer, as employers. Let's analyze what's happening with H.R. 1 and put commitments to it, that if what CBO says, what Kaiser says, what I think is going to happen, and I hear in my community, happens anymore, that we work to stop it. And we can stop it in appropriations, or we can stop it here through policy. But it's unfortunate that we had to have what happened today. I still very strongly feel I go with the process, the rules. You ruled, we were outvoted, but those words were unfortunate at the least and should have been strucken down. Mr. Woodhouse and all the witnesses, we appreciate your testimony, and we want to protect all of your ability and your enthusiasm to
Mr. Witnesses under the 5-minute rule. I will recognize myself for 5 minutes. I was recently reading some material from Milton Friedman, and he said, you know, he would like to privatize everything, but the government has to do some things. The only problem with the government is it costs twice as much to do it. And that seems to be the dilemma we have in healthcare. Mr. Gilfin, employee participation in direct contracting programs is associated with a reduction in healthcare costs, improved health outcomes, and increased productivity. Can you share some of the quality metrics that may be used to measure healthcare volume and cost and the improvements you've seen in patient care?
Thank you, Mr. Chairman. Direct contracting can help shift the focus from volume to value. Employers and providers measure success through outcomes, access, and patient experience metrics, as well as through costs. Quality measures typically include improved utilization of preventive screenings, chronic disease management, reductions in ER visits, hospital admissions and readmissions, medication adherence, patient-reported outcomes, and timely access to care. Cost measures focus on total cost of care, including overall spending trends and the substitution of lower-cost interventions rather than potentially avoidable hospitalizations and ER visits. For example, direct primary care has helped improve access in chronic condition management. While traditional primary care wait times might average around 21 days or more, team-based DPC can offer same and next-day access through in-person, virtual, or digital options. That access changes utilization patterns. In DPC arrangements, lower-cost virtual visits account for 15 to 34% of visits, compared with only 4% in a non-DP setting. One member company's direct primary care arrangement near Mesa, Arizona showed 14% reduction in ER utilization. That's not because people who needed to go to the ER didn't go, it's because they were taken care of and they never needed that visit in the first place.
Right. And this improvement in health outcomes, did it help contribute to happier, more productive employees?
Yes, in fact, that MESA program achieved a net promoter score of 88. So that's the score that patients were giving it, 88, whereas they gave most healthcare 58%. So much higher rated. Broader benchmarks show similar results. A company called Hint Health partnered with DPC practices nationwide to measure patient experience. More than 1,500 direct primary care patients across multiple states, they rated it 89%, including a 97% score for contact and access. The study also yielded an NPS score of 85. So in healthcare, that score reflects unusually strong patient trust, satisfaction, and willingness to recommend the care model.
Mr. Newman, in a free market economy, the only way to bring down pricing is competition. And we've heard today about how large employers are able to create savings through direct contracting. What barriers do smaller employers face in entering into similar contracts because they don't really have competing factors in securing their health care? And you have created that, and how does that work?
Yes, thank you for the question. You are right. You know, that we always think of solutions as being for only the large, but in fact, NOMI's core mission is to do it for the small and the mid-size who don't have other options or don't have other paths to access those things. You know, when you think about analytics and payments, it is wildly national, but networks are very, very local, right? It's the town, it's the county, it's the state that you're in. It's actually a level playing field for small and mid-sized employers when they're concentrated in a single area. And these employers are manufacturers, hospitality, restaurants, universities, unions, school districts. And when we unleash their kind of market power in this place, it's a question of how do we make it easy? We need to make it easy for the provider to participate. We need to make it easy for the employer to participate, because guess what? They're all hometown heroes, and they want to help and take care of each other. So, the pure irony when you're talking about price and marketing competition is that the opportunity to save is right in front of us. A price isn't a price in healthcare. $1 of negotiated care isn't $1 to any provider who ever expects to get it for whatever price they list, and an employer's paying $1.20 or $1.30 to even get it. And at the end of the day, when that provider only collects 70 cents on the dollar, we don't have to fight over contracted rates or you name it. Let's pay them what they actually end up receiving at the end of the day, pay them more than that, and make it super easy and simple for any employer of any size to tap into it. And that's the real opportunity. The money's right in front of us.
Good. Thank you very much, and I yield.
Thank you, Mr. Chairman. Mr. Gelman, obviously, I don't think it's much of a challenge to be able to lower costs and improve access for a few people. Is there any chance that this could be comprehensive or a universal strategy for everybody?
When we canvassed our members to ask them what kind of direct contracting they were doing last week, and we actually heard from many members that they had comprehensive direct contracts that were covering, if not their entire employee population, but the entire population in certain areas where they had a large volume of care. And what they found was independent studies showed that the rates that they were getting in those direct contracts were lower, which means that every patient that was covered through one of those plans that was a direct contract plan ended up having lower premiums.
If you're not part of that negotiating plan, you're not getting the benefits of that plan, is that right?
That is correct.
Now, the bills the prices that you negotiate public?
So we do have to disclose in our transparency and coverage disclosures what we pay for healthcare.
So if someone were sued for going to the emergency room and not paying, they could obtain what they negotiated with you for the price and compare it to what they'd been sued for.
Yes, potentially that would be a very good idea. If you're sued by a hospital system, you should look at transparency and coverage data and see what they're accepting rates from others.
Mr. Woodhouse, if an employer gets a good price, what happens to everybody else's price?
I mean, everybody else's price would benefit if an employer gets a good price.
And how does, what does cost shifting of uncompensated care mean?
Well, I mean, I think, you know, the big concern is we have 15 million people potentially going to lose health care. 8 million already have, 5 million on Medicaid, 3 million on the ACA marketplace already. And these people will get sick. They will need care. And we know from study after study and talking to insurance companies who we talk to about these issues that there are upward prices on premiums when uncompensated care moves costs throughout the system. And look, like I said, these costs are not just higher premiums. We have higher costs to taxpayers in many states that are trying to keep rural hospitals open. This H.R. 1 cuts to Medicaid and elimination of the ACA tax credit is a cascading disaster for the healthcare system. It's much more immediate, much more existential than anything else we're discussing here today.
Now, how effective can a plan be if can a strategy be if it depends on employers' competence in negotiating health prices? Right now, all they do is guess if they get 3 bids from insurance companies and hope for the best. But if they have to negotiate with hospitals and doctors, how effective as an overall strategy would that be?
Well, look, I'm not taking any issue with the issue of this direct contracting. I think we think virtually everything should be on the table. But I will tell you right now what the American people are really focused on in terms of their health care costs. I mean, obviously people losing coverage are very concerned. The 20 million people who have seen their ACA premiums skyrocket because their tax credits were taken away are very concerned. But 90% of the American people want more done on drugs. And that is one of the biggest drivers of people's concern about cost in the healthcare system. The bill that you've introduced with your colleagues would go very far in dealing with a lot of the issues the American people are concerned about in terms of cost in the American healthcare system.
Has it ever been effective to rely on consumers to compare prices with doctors?
Not in my experience.
And if the idea is to get Americans needed health care, how helpful is that what they call big beautiful bill and the decision not to extend the enhanced tax credits?
Well, it's a real problem. We've seen 3 million people drop coverage lose coverage in the marketplace. 5 million are losing it through Medicaid. But that just scratches the surface. I mean, remember, every study, KFF, other studies have shown that those people who are deciding, many people are taking a lower plan, what you'd call a bronze plan, high deductibles, high out-of-pocket costs, and then many are paying, double and triple premiums to have health care coverage, and then they have to make decisions about how they can afford groceries, how they can afford rent. And this was a choice, right? Y'all make choices here. You chose to do $1.7 trillion in tax cuts to billionaires and corporations instead of continuing health care for millions of Americans. That was a choice. And so that is why many Americans are seeing higher health care costs and losing coverage.
Let's break down a House hearing with a long title and a simple fight underneath it. It was called Direct Contracting, a Prescription for Lower Health Care Costs. 6 members questioned the witnesses, and like most health care debates, it was really 2 arguments in one room. One side focused on the price of care, the other focused on who stays covered. Both are trying to fix the same broken system. Here's the split. One side, led by the Republican members, argued that health care costs too much because of middlemen, paperwork, and waste, and that letting employers and patients contract directly with doctors would bring prices down. The other side, led by the Democratic members, argued that the bigger risk is people losing coverage, and that the current system, whatever its flaws, keeps millions insured. So set the 2 lenses side by side. The market lens asks whether cutting out the middlemen lowers the price. The coverage lens asks whether people keep their insurance when the rules change. This breakdown checks each against the record, not the volume of the argument. And one ground rule. A fact check isn't about which party you like. It's about checking each specific claim against the evidence, the spending data, the studies, and the budget scores. Some claims from both sides hold up well. Some are oversold. We'll take them one at a time. Start with the thing almost everyone in the room actually agreed on, because it's the foundation for both arguments. Here's the anchor number. The United States spends roughly $4.9 trillion a year on healthcare, close to 18% of the entire economy. That's far more per person than any other wealthy country, without better results on many basic measures. Nobody at the hearing disputed that the cost problem is real. And a big chunk of that spending never touches a doctor or a nurse. Study after study estimates that around a quarter of U.S. health spending goes to administration, billing, coding, prior authorizations, and paperwork. That's the target both sides claim they want to cut, even if they disagree on how. And here's the comparison that frames the whole debate. Other wealthy countries spend around half of what America spends per person, and most of them cover everyone. That gap is the reason a hearing like this exists at all. The money is going somewhere, and both sides are trying to find it. One more piece of shared ground. Prices in American health care are famously hard to see. 2 patients can get the same procedure at the same hospital and be charged wildly different amounts, and almost nobody can find out the price in advance. Both parties say they want that fixed. It's worth remembering when the shouting starts. So keep that in mind as the fight unfolds. This isn't a debate between people who care about costs and people who don't. Both sides say the system is too expensive and too complicated. The real disagreement is about the cause, and about which fix does more good than harm. Now the Republican case, built around the hearing's title, Direct Contracting, and its cousin, Direct Primary Care. Chairman Rick Allen and Congressman Bob Onder carried most of it. Here's what direct contracting means in plain terms. Instead of running every payment through an insurance company, an employer contracts straight with a doctor, clinic, or hospital for a set price. The pitch is that fewer layers means less paperwork, clearer prices, and lower cost. On the logic, it's a reasonable idea worth testing. Direct primary care is the version patients might actually see. You pay a flat monthly fee to a primary care practice, and in return you get visits, basic tests, and easy access, with no insurance claim for routine care. Supporters say it restores the simple doctor-patient relationship and takes billing out of the exam room. The fees are real and fairly modest. Most direct primary care practices charge somewhere in the range of $50 to $100 a month for an adult. For people who use a lot of primary care, that can be a genuinely good deal, and the model has been growing across the country. But here's where the fact check has to be careful. The evidence that direct primary care lowers total costs is promising, but still thin. Some employer programs report lower emergency visits and hospital use. Others show little change once you account for who signs up. It may help, but the large, rigorous studies aren't there yet. And there's a limit built into the model. A flat monthly fee covers routine care, but it does not cover a heart attack, a cancer diagnosis, or a long hospital stay. For those, you still need real insurance. So direct primary care is best understood as a complement to coverage, not a replacement for it. That distinction matters for the whole debate. Where direct contracting has the most real-world traction is with large, self-insured employers, the companies that pay their workers' medical bills directly rather than buying insurance. Some of them have negotiated straight with hospital systems and reported real savings. That's the strongest evidence for the model, and it's worth taking seriously. But notice who that leaves out. A giant employer has the lawyers and leverage to strike its own deals. A small business, a gig worker, or someone between jobs does not. So the model that works best for the largest players may do the least for the people with the least bargaining power. That's a fairness question. The hearing mostly skipped. Congressman Onder put a lot of weight on a specific villain in the cost story, the middlemen who sit between patients and their medicine. Here's the fact that gives that argument teeth. Just 3 pharmacy benefit managers, the companies that manage drug benefits, control around 80% of all prescriptions in the country. That kind of concentration gives a handful of firms enormous power over what you pay at the pharmacy counter. And this is where left and right quietly agree. Investigators from both parties have criticized practices like spread pricing, where the middleman charges the employer more than it pays the pharmacy and keeps the difference, and complex rebates that can steer patients toward pricier drugs. Reining in these middlemen is one of the few genuinely bipartisan ideas in health policy. Insulin is the example everyone reaches for because it's so clear. The medicine is decades old and cheap to make, yet American patients have paid many times what patients abroad pay, with the gap disappearing into the supply chain between the maker and the counter. When a cap finally passed for some patients, it showed how much of the price was never about the drug itself. There's also a fairness point buried in the rebate system. Because middlemen often take a cut based on a drug's list price, the system can quietly reward higher prices, not lower ones. Fixing that doesn't require picking a party. It requires transparency, so employers and patients can finally see where the money actually goes. So give the market case its fair marks. On middlemen and paperwork, the critique is strong and widely shared. On direct primary care, the idea is sound and worth expanding. The overreach is only in the claim that these steps, by themselves, solve the cost problem. They help at the edges, they don't rebuild the whole system. Now, the other side of the room. Congressman Mark DeSaulnier and Congressman Bobby Scott turned the focus from price to a different question. What happens to people who lose their coverage entirely? Start with where coverage stands. In recent years, the share of Americans without health insurance fell to around 8%, one of the lowest rates ever recorded, largely because of the coverage expansions of the last 15 years. The Democratic members argued that protecting that gain should come before any experiment. And here's the scale of what's at stake. Public health insurance programs cover more than 80 million Americans, including a large share of the nation's children, births, and nursing home residents. This isn't a small niche program. When the rules change, they change life for a very big slice of the country. That's the context for the coverage side's urgency. When you're talking about programs that cover tens of millions, even a small percentage dropped is a large number of real families. The Democratic members argued that the direct contracting conversation, whatever its merits, shouldn't distract from a much larger number of people at risk of losing coverage entirely. This is also where the hearing got heated. One of the witnesses, a health coverage advocate named Brad Woodhouse, presented figures on how many people could lose insurance under proposed changes. A Republican member sharply challenged those numbers and questioned the witness's credibility, and the Democratic members rose to defend him. So who's right on the numbers? The honest answer is that coverage loss estimates depend on assumptions, and reasonable analysts land in different places. But the direction isn't really in dispute. The nonpartisan Congressional Budget Office has repeatedly found that tightening eligibility and funding does reduce the number of people insured. The fight is over how many, not whether. And the coverage argument isn't only about the uninsured. It's about who pays when an uninsured person still needs care, because in America they always eventually do. Here's the mechanism DeSaulnier kept returning to. By law, emergency rooms have to treat people whether or not they can pay. When someone uninsured gets care they can't afford, that cost doesn't vanish. It gets absorbed by the hospital and passed along through higher prices and taxes to everyone else. Coverage isn't just about the individual, it's about who carries the bill. And the sums are large. Hospitals provide tens of billions of dollars in uncompensated care every year, care that patients couldn't pay for. When coverage shrinks, that number tends to rise. and it lands hardest on the hospitals with the thinnest margins. Which leads to the part of the coverage argument with the sharpest local stakes, rural hospitals. Rural hospitals run on razor-thin margins and depend heavily on public insurance programs to stay open. When coverage drops and uncompensated care climbs, these are the hospitals most likely to cut services or close their doors. And when a rural hospital closes, the whole community loses its emergency care, sometimes for 100 miles. That's a coverage question with a very physical answer. And this isn't hypothetical. More than 100 rural hospitals have closed or stopped offering inpatient care over the past decade or so, and hundreds more are flagged as financially at risk. Coverage policy and rural hospital survival are tied together tightly, which is why the argument carries real weight in exactly the districts that lean the other way politically. In his closing, the ranking member tied it all to the year's big legislation, the reconciliation package often called H.R. 1. The warning was specific. The package tightens eligibility and funding for public health insurance and adds new paperwork requirements to stay enrolled. The concern isn't only that some people lose coverage on purpose, it's that many lose it by accident, tripped up by the paperwork, and end up back in the emergency room for care they could have gotten earlier and cheaper. And the scorekeeper weighed in. The nonpartisan Congressional Budget Office estimated that the changes would leave millions more people without insurance over the next decade. You can debate whether that trade is worth it for the savings, but the coverage effect itself is not a partisan invention. It's the official estimate. The sharpest fight was over work requirements, rules that make you prove you're working to keep your coverage. Supporters say coverage should come with responsibility. Critics point to the states that tried it and found most people who lost coverage were actually eligible, just tangled in the paperwork. Both the principle and the track record are real, and they point in different directions. Now back to the flashpoint, because how you read it says a lot about how you read the whole hearing. Here's the neutral version of what happened. A Republican member accused the coverage witness of misleading the committee. An objection was raised, and after a pause, the chair allowed the questioning to continue. It was dramatic television. But drama isn't evidence, and a raised voice doesn't settle whose numbers are closer to right. So separate the theater from the substance. On the theater, both sides scored points with their base. On the substance, the checkable question is narrow. Were the witness's coverage figures within the range that neutral analysts accept? And on that, his direction matched the official estimates, even if you could argue the exact number. This is why witness credibility fights are worth watching, but rarely decisive. In the end, the committee doesn't have to trust any one witness. It has the Congressional Budget Office, the spending data, and the studies. Those sources don't shout, and they're the ones a fair viewer should weigh most heavily. So let's total it up honestly on both sides of the room. On the cost side, the attack on middlemen and paperwork is strong and bipartisan, and direct primary care is a promising idea, but not a whole system cure. On the coverage side, the warning that cuts raise the uninsured, uncompensated care, and rural hospital risk lines up with the official estimates. Two real sets of concerns pointed at the same broken system. None of this tells you how to vote. You can believe that middlemen are ripping people off and also believe that losing coverage sends people to the ER at everyone's expense. Those two truths don't cancel out. The mistake is treating this as one fight with one winner, when it was really two problems that share the same overpriced system. Give each side its due. The cost hawks are right that a quarter of the money never reaches care, and that a few middlemen hold too much power. The coverage side is right that when people lose insurance, the bill doesn't disappear, it just moves, usually to the emergency room and the rural hospital. A viewer who holds both understands this hearing better than one who only cheers a side. And notice the honest overlap. Direct primary care works best for people who already have insurance for the big stuff. Cutting middlemen helps everyone, insured or not. The policies that draw the widest agreement are the ones that lower price without stripping coverage. That's the narrow lane where this fight could actually produce something. If you want a preview of what could actually pass, look at price transparency and middleman reform. Both have real support in both parties. Both attack cost without touching who's covered, and both have already moved through committees before. When a hearing generates more heat than light, those are the quiet places where a deal is still possible. And here's the honest tension neither side fully owned. Real savings and universal coverage can pull against each other in the short run because covering more people costs money up front even if it saves money later. Pretending that trade-off doesn't exist is how both parties oversell their plans. Naming it is how you actually judge them. So where does it leave us? with a system that genuinely costs too much, and a real disagreement about whether the bigger danger is the price of care or the loss of it. A serious country can work on both at once, and this hearing is a good argument for why it has to. Watch 3 things from here, and the first is the evidence on direct contracting. Whether the bigger, more rigorous studies show it lowering total costs, not just shifting them. If the data comes in strong, expect it to spread fast. If it stays thin, expect the enthusiasm to cool. Second, the middlemen. Whether Congress actually passes the bipartisan reforms on pharmacy benefit managers that both parties keep endorsing, or whether the lobbying quietly runs out the clock again. This is the one area where a real, near-term win is genuinely possible. And third, coverage. Whether the changes in H.R. 1 play out the way the Budget Office projected, and how many people are dropped by paperwork rather than by choice. That number, when it arrives, will be the clearest test of who read this hearing right. Those answers will come on the record. The system won't get cheaper because we argued louder, and no one gets covered because a hearing ran hot. The work is in the studies, the reforms, and the coverage numbers, and that's where we'll keep watching. That is our breakdown. Stay with us.